Well, folks, it's 7:35. I just wanted to just kind of reflect for a moment and say it's hard to imagine that we started this about a year ago, exactly in April, 1 year ago. Have had so many great lectures from so many different people, and today is not going to be any different. It's really with great pleasure that I introduced Dr. Kapil Gupta. Dr. Gupta is the co-director for point of care ultrasound at the University of Washington in Seattle, and my partner in crime. He has clinical training and experience in cardiac anesthesia and ICU care, as well as transplant anesthesia. And we're so excited that he's part of our department now. He has experience in point of care ultrasound, having run workshops internationally, and having had training from and working with kind of global leaders in point of care ultrasound. So his expertise is vast, and we're really excited to have him talk with us today. Thanks, Kapil.
Yeah, thanks, Sarah, for the kind introduction. I'm humbled by your comments. So I'm going to share my screen now, and I really appreciate Sarah's vision of our program in our department. She's been amazing and brought UW in the last couple of years to a different level when it comes to point of care ultrasound. So thanks, Sarah. So I hope my slides are seen. Are they visible now?
Yes, I can see them.
Okay. So one of my topics of my choice has been lung ultrasound. This is how I do it. So for lung ultrasound, it doesn't move. Yeah. So when the patient is supine or even in sitting position, I generally scan 6 positions in any patient. Position 1, position 2, 3, 4, and 5, and 6. So how I do it is I place a horizontal line just below the nipple of the patient and 3 vertical lines. One is, as we can see in this picture, parasternal. The second is anterior axillary line. And the last one is posterior axillary line. So zone 1 shows us about the anterior, zone 1 and 2, about the anterior lung. For lateral portion of the lung, we scan zone 3 and 4. And zone 5 and 6 is in lateral position. That is, in that case, we have to make the patient lateral, in lateral decubitous position to be able to scan the posterior portion of the lung. So we use high frequency probe for scanning periphery of the lung to see any lung sliding or lung comets. And for low frequencies, we use low frequency probe to scan deeper lung tissues, sometimes even for consolidation. So this is what I said: supine position for scanning anterior and lateral lung areas, and lateral decubitous position to scan posteriorly. Well, in 2014, when I was taking a talk in one of the conferences, I met this Dr. Lichtenstein. His talk was after me, and this is what he told me about his favorite positions. He called them, this guy, Dr. Lichtenstein, is the father of lung ultrasound. He's the one who started lung ultrasound, I think, almost 15, 20 years ago. So he says he scans 4 main areas. That is, those are known as 2 blue points and 2 collapse points. So if you put your hands just below the clavicle, both the hands, as shown in this picture, the junction of the middle and the ring fingers of both the hands are his 2 blue points. And if you make horizontal lines at both these blue points, which meet the posterior axillary line, then just behind that are the 2 collapse points. He said you can find 99% of the pathologies if you scan just these 4 points. Coming down to the principle, we know ultrasound images are created because of the difference in acoustic impedance between the tissues. but normal lungs are aerated, so there is no acoustic mismatch. Beams are rapidly dissipated by the air. So as we can see here, this is a normal picture of the lung and the pleura. So what we can see here is you have on the top the skin, the subcutaneous tissue. The skin, the subcutaneous tissue, the muscles. I'll play this again. So this is your pleura. This is your pleura. This moves to and fro. And this is the hyperechoic horizontal line. This is in the M mode actually. And this pleural line slides with respiration. That is the to and fro movement, we call it. So you can see this pleura, the movement again. So this is a healthy lung. Coming down to second thing, that is A lines. The A lines are horizontal, regularly spaced, hyperechoic lines, which are reverberation artifacts of pleural line. These lines, all these lines, they are below this pleural line and they are reverberation artifacts. And that means it is a healthy and normal lung. That represents basically air in the lungs. And they are motionless. They indicate, this is what we see, how we see in the video. They indicate air. So in B mode, we also call it as bat sign. As you can see in the center, there is the rib. And on both the sides, you have this pleural lines, this to and fro movement. This is also known as A profile or bat sign, and it reflects a normal and healthy lung. This is what we all want to see all the time. And this is in B mode, that is the brightness mode. When we change the mode of the ultrasound machine to M mode, that is the motion mode, this is what we will see. So we see again the skin, the subcutaneous tissue, and the muscles. They see as these horizontal lines, and then this is the pleura, and then you see this granular tissue just below the pleura, and this is known as seashore sign. We all know seashore. We all love seashore, so that's healthy. That's a healthy lung. So just in a bigger picture, this is the M mode showing a seashore sign. That is a healthy lung. The granular tissue, the pleural, the pleura, as well as the skin, subcutaneous tissue, and the muscle. Now coming down to lung pathologies. So when we have pulmonary edema or pulmonary fibrosis, the air content decreases. Now the acoustic mismatch needed to affect the ultrasound beam is created, and some images do appear. So this is blue protocol, which was described by Dr. Lichtenstein. This is the basis of most of the ultrasound findings. So first thing is you see lung sliding, whether it is present. If it is present, whether B lines are there, that is B profile, whether A profile is there, or C profile is there. If it is absent, you see whether there is B profile or there is A profile. Depending on that, we'll make the diagnosis. So I'll discuss the basic pathologies in detail now. So what happens when there is extravascular lung water, or we call it as interstitial syndrome? The interlobular septa are thickened. There is edema. So the reflection of ultrasound beam creates comet tail reverberation artifacts, which are known as B lines or lung comets. So this is what B lines look like. They are basically discrete, laser-like, vertical, hyperechoic lines. They arise from pleura and extend to the bottom of the screen without fading. They move synchronously with respiration, and they always move in concert with lung sliding. So this is very important and very highly sensitive and specific finding. So these are some of the comets. You see in different pictures, you have increased number of comets. This is one of my patients, and the surgeon, we did this hip replacement surgery, and in the patient was shifted to the room. Next morning, surgeon came to us and said the patient has had a reaction to albumin. Saturation is around 90%. There are some coarse crepitations in the chest. It's 10-year-old picture. And we did lung ultrasound, and we saw that there were B lines present on both sides of the lungs. So it was clear it is not any allergic reaction, it's overload of albumin, the volume. So there was hypervolemia. We gave Lasix, and there was some urine output production. So we didn't even have to intubate this patient, and he was managed and he was fine. So the importance is that B lines quantify pulmonary edema and they clear after adequate medical treatment. So as the urine was coming out, we realized the B lines decreased every half an hour. Within a couple of hours, the patient was absolutely fine. The B lines disappeared. We can also use it in kidney transplant patients to give volume. So historically, whenever I have started a new kidney transplant program in any surgeon, in any hospital with a new surgeon, I try to use it when I'm giving fluids, especially in some cardiac patients with low ejection fraction, to see if I'm exceeding the volume which is needed. So how many B lines we can see in this picture? There are none actually. Again, in this picture, there's no B line. Why? These are known as Z lines. It's important to differentiate them from the B lines. They can confuse us. They are less echogenic than the pleural line. They are usually taper off after 2 to 4 centimeters. They do not erase A lines, and they do not move with lung sliding. So these are some important differentiating features with B lines. Now coming down to pneumothorax, which is another important differentials in our day-to-day practice. So I generally use high frequency linear probe, which has more than 5 megahertz frequency. Remember, for pneumothorax, it is important for pneumothorax or for pleural effusion. What is important is where you scan. So for pneumothorax, we'll have to scan in the superior portion, and especially if it's possible to make the patient sitting, then we do it in the sitting position. And because we all know air moves away from gravity on the topmost portion of the lung. So it's better to scan in the right place. Just like for pleural effusion, we scan in the base of the lungs or in the gravity-dependent zone where pleural effusion is there. And actually, whenever I take this talk, I always say that we use ultrasound in lungs based on the clinical findings. First, we see, okay, what are the clinical findings? What are the differential diagnoses? And then we rule out and come down to a particular diagnosis based on our lung ultrasound findings. In fact, recently I was doing a case in our hospital here, and I was called in the other OR to help because the patient was desaturating by the attending. So it was an aortic aneurysm dissection, and they were giving blood for the bleeding. When I did echo and lung ultrasound, I realized there was pulmonary edema all over, and actually there were B lines all over. And with echo, we found that the ejection fraction was hardly 15%. So instead of what was being done was a lot of volume was being given, we changed our plan. We now had to take out volume and in fact gave more of inotropes. We started ADR infusion. So that's how important lung ultrasound can help us to find. So coming back to pneumothorax, so one thing is lung sliding is absent. A lines are always present because there is air, and B lines are absent. And there is a point known as a lung point, or on M mode, we see stratosphere sign instead of seashore sign. So this is what I see. This is in M mode. That is the motion mode. So on the left side of the screen, we see a healthy lung where you have parallel lines on the top that represents skin and subcutaneous tissue as well as the muscle, and lung which is represented by granular tissue, by the granules. Whereas on the right side, we have parallel horizontal lines which reflects presence of pneumothorax throughout the screen. So there are a number of horizontal layers, and the junction of these 2 points where the healthy lung meets the pneumothorax is the lung point, or where the seashore sign becomes the stratosphere sign, that is the lung point. So this is the same pictures. The lung point is sudden change from C-show to stratosphere change, or in B mode, change from mobile to immobile lung. Because in B mode, there'll be always a place where there is absence of air, and in that part of the pleura would be moving. So there will be presence of to and fro movement, whereas where there will be pneumothorax, there'll be no to and fro movement. So this is one of the patients in my ICU. So let me see if I can play this video here. So you see all these parallel lines here. So this is basically absence of granular tissue, and that is also known as barcode sign, and that is pneumothorax. So this is consolidation. Another important diagnosis we can make is consolidation. As in chest X-rays, when we do lung ultrasound, you will see hyperechoic air bronchograms with move with respiration. This is present in the early phase, that is phase 1 of consolidation, stage 1 of consolidation. This is one of my patients in the ICU. You see here, if you see here and here, there is some air bronchograms just below the pleura. So that was the early stage of consolidation. So we looked at the antibiotics after looking at that. This is the stage 2 of consolidation, where you will see some B lines here in just one portion of the lung, not in throughout the lung, some B lines, but not as many. And also sometimes there is absence of lung sliding. So pneumonia or consolidation can be diagnosed by presence of A lines on one side of the lung and B lines on the other side, or B lines are present and lung sliding is absent. So if the B lines are present and lung sliding is absent, that can be because of consolidation in that particular area of the lung. Or C profile. Now, what is a C profile? It's also known as shred sign or fractal sign. As we can see in this picture, the topmost portion, the black portion or the hypoechoic portion, that is the consolidation. Basically here, the lung consolidation does not involve the whole lobe. The consolidated lung tissue is subpleural hypoechoic region with irregular deep border, which is adjacent to the normal aerated lungs. On the left side, we have on the topmost, the black tissue is the consolidation, and below that we have the healthy lung. Or in the stage 4, that was stage 3 of consolidation. In stage 4, you have something known as hepatization, that is massive consolidation involving whole of the lobe of the lung. No aerated lung tissue is present. There is tissue-like pattern of the lung, and this is known as hepatization of the lung, as shown in this picture. Coming down to pleural effusion, the probe is placed in intercostal space. You will see the dark structure in the dependent lung areas. So it's also known as quad sign on the B mode, or it will be the shape of a trapezium, basically, as we can see in the picture. We all know pleura is basically the two pleura. One is the visceral pleura, which is just abutting the lung, and the second one is the parietal pleura. So the visceral pleura always moves with the lung, whereas the parietal pleura moves separately. When there is no pleural effusion, they move together and they rub together. That's what creates the to and fro movement. But when there is pleural effusion, as you can see in this picture, what we can do is we can start the M mode. We can put the M mode on. What we see is the dynamic sign or the sinusoidal sign. What is that? On the right side of the picture, we will see that in the M mode, there is this visceral pleura, which is abutting the lung. It moves towards the parietal pleura during inspiration. And this inspiratory shifting of visceral pleura with decrease in apparent thickening of effusion is known as sinusoidal sign. This is one of my patients, not a very good picture I could take. This is the, again in ICU. I'll play it again. So you can see, here we go. You can see this here. This is M mode and this sinusoidal sign is here. So this is some effusion, and this is known as sinusoidal sign. Or sometimes there is a lot of fluid, like in this picture here. Pleural fluid it is so huge that it collapses the lung. So left lung is collapsed here into a small mass, and it is compressed by the effusion. Or this is another picture of pleural effusion from the ICU. And this one, you can see this is known as jellyfish sign. You can see this collapsed lung. This is the liver. This is the lung, which is collapsed here, and a lot of pleural fluid here around this. So this is again another nice picture I could take it. Okay, so coming down to another important thing that I like to see with my lung ultrasound is presence of endobronchial intubation. Here there are two things. One is absence of lung sliding in that portion of the lung which is not being ventilated. Like if there is a right mainstem bronchus intubation, then left lung will not be ventilated. So there will be absence of lung sliding in the left side. And there will be pulsation of the lung, which is transmitted due to the heartbeat. This is the sign of non-ventilated lung. Coming down to sensitivity and specificity, all of these are highly sensitive and specific. We see here negative predictive value of pulmonary edema is 99%, and pulmonary embolism can also be diagnosed. Pneumothorax is easily diagnosed, and even pneumonia sensitivity and positive predictive value is quite high. So this is the blue protocol again, as we discussed. So always we see for the lung sliding, whether it is present or it is absent. If it is present and there is B profile, there is presence of P lines, then this is known as pulmonary edema. If there is A profile, that is everything is normal, then you have to do venous analysis, find for any thrombosed veins. So you can, if there is presence of thrombosed veins, it should be pulmonary embolism. You have, in that case, I would do echocardiography and see for any right heart dilatation as well as McConnell sign. McConnell sign is basically the sparing of the right ventricular apex movement, whereas the free wall does not move very well. That's pathognomonic of pulmonary embolism. So if there is presence of A profile on one side of the lung and B profile on the other side, or there is presence of C profile, that's pneumonia. And if the lung sliding is absent and there is B profile, then you have pneumonia. And if there is A lines plus lung point, it can be pneumothorax. So coming down to another important part of my talk is about diaphragm. We can see use the diaphragmatic excursion in our day-to-day practice in ICU to wean our patients, even in OR sometimes. If you think there's a need, there might be some diaphragmatic involvement, or after a block like an interscalene block, if you think, especially in a patient with some underlying pulmonary pathologies. So what I do is I do two things. One is dome excursion, and the second is dome thickening and thickening during inspiration. So I use curvilinear probe, place it on the anterior subcostal region between mid-clavicular and the mid-axillary line here. And I put my M mode on. So on the picture A, the curvilinear probe, place it between mid-clavicular and mid-axillary line. Then I put on the M mode, as we can see in the picture D. In the picture C, we see in the B mode, what we see is liver and the diaphragm. And in picture B, we see the placement of the A and B, we see the placement of the probe. So what we see is this kind of a mountain, which appears, that's the movement of diaphragm. So again, this is in M mode. And I made a small video, not a great quality of the video, but so this is how I do it is, you see the movement of the diaphragm and you see this mountain coming up. So I freeze that mountain and I measure the height of this mountain from the baseline. So that is the diaphragmatic excursion. It's pretty easy to do. So normally it should be more than 1.1 centimeters in quiet breathing, and in deep breathing, it's different from men and women. In men, it should be more than 4.7 centimeters, and in women, it should be more than 3.7 centimeters. Coming down to the second important thing that I do is diaphragmatic thickness and thickening during inspiration. So for this, I use a linear transducer, and I assess the diaphragm at the zone of apposition. That is the chest area, as we can see in this picture, where the lower rib cage reaches the abdominal contents. Generally at the 8th intercostal space between anterior axillary and mid-axillary lines, perpendicular to the chest wall. So what we see is, you will see lung here on the left side of the picture, right side will be liver, on top will be subcutaneous tissue and subcostal muscles. And then below them, you will see, as in this picture, you can see the diaphragm. That's all seen in M mode. So you have to measure the thickness of the diaphragm during inspiration as well as the expiration. And it can be easily seen as the maximum thickness and the minimal thickness. The diaphragm will contract during inspiration. So diaphragm muscle thickness increases during inspiration, and this thickening fraction is thickness at end inspiration minus thickness at end expiration divided by thickness at expiration. So the maximum thickness minus the minimum thickness divided by minimum thickness. So this is one of the patients. This is the diaphragm. You see how big it becomes with movement, so clinical applications is for weaning. Any diaphragmatic excursion more than 25 have higher, 25 millimeters has higher likelihood of success of spontaneous breathing trial. Diaphragmatic thickening fraction more than 30% during spontaneous breathing trial, again, is generally associated with successful weaning. Thank you.
Kapil, thank you so much for that amazing lecture. Especially, I think for a lot of us, diaphragmatic evaluation is something that, you know, folks are really working on getting better at and getting more exposure to for vet weaning. And then, of course, the lung pieces that you presented were really wonderful. I just wanted to open this up to the group to see if anyone had any questions that they wanted to ask Kapil about the talk today, or about lung ultrasound, or ultrasound in general. Feel free, if you have any questions, to unmute yourself and share them with us. David.
Thank you very much for the presentation. Clear. I missed the location of where you put the probe when you're doing the measuring the diaphragmatic excursion. If you could respond to that.
Thank you, David. So I'm just going to recap. So a kind of an explanation of where you put the probe when you're trying to evaluate for diaphragmatic excursion. Is that correct?
Yes,
Great. Thank you, David. Yes, Kapil, could you share where you place the probe when you're trying to evaluate for best place for diaphragmatic
I'll share the screen
excursion?
again and I'll show that video again. Just a second. Here we go. I'm sharing my screen, and this is the lung ultrasound. So here, so for diaphragmatic excursion, can you see my screen now?
Yes, we can see it.
Okay, so I place it at the anterior subcostal region here, between the mid-clavicular and mid and anterior axillary line. So you will, but there is no one fixed point. So once you place between the mid-clavicular and the anterior axillary line, you'll have to scan a little bit, tilt, and like we use the probe in all kinds of ultrasound whenever we use. The main thing is we place it between mid-clavicular and anterior axillary line, and we put the M mode on, and anterior subcostal region, just below the, again, around 8th intercostal space, I would say.
Thank you.
All right.
Thank you, David, for that great question. Amy Morris asked a question on the chat. Amy is one of our pulmonary critical care point of care ultrasound experts here at the University of Washington. And Kapil, she said, I'm out and about, so no video, but nice to see you, Kapil. Diaphragmatic thickening can be really challenging in larger patients. Any tips or tricks you can share to find the zone of opposition and measure that structure in patients who are larger?
Very good question. I think it's just about practice. Anything like the more we practice, the better it is. How I became better at this is I did a research on this, and I had done almost 50 to 100 scans. Then I realized I became good at it. But it's all about all those basic movements of the probe, that is tilting and sliding and rotation of the probe. I think that is what helps. No particular, I would say no particular trip, like, and no particular way of doing it. It's just you place the probe there and then move around that place.
And I think to your point, that's a really good point. I think, of course, practice is key for recognizing what the structures are and how to kind of manipulate. One thing that I wondered too is if it isn't very helpful to make sure you find the liver, make sure that you can at least see the liver, because sometimes in patients who are large, you don't really know where the structures are. So if you put the probe kind of, I don't know if you can go to that slide, Kapil, about where you were showing the point of opposition on your lecture. But I think, sliding to make sure you see the liver and then you're kind of above, looking in that way above that area, that may be helpful. So even though you're using a linear probe, sometimes for this, you could put on a curvilinear probe, make sure you found the liver first, and then, so that you knew your positioning was appropriate, and then swap to your linear probe and see if then you could focus in on the diaphragm.
Yeah, that makes sense. Also, when I started doing this, zone of apposition used to be a challenge because you have to, for the best results, you should be at the zone of apposition. So with time, I realized that I used to scan up and down. After coming down to see the pleura, the diaphragm, I would scan up and down and see wherever the lung and the liver were together. Like that was, again, another zone of apposition. And I would take the measurements there, because sometimes the measurements change a little bit at various places of the diaphragm, but that is where most of the studies have validated the results. So, but it takes time, but you will do it. Like once you're doing maybe 20, 30 scans, after that, it's not that difficult.
Thanks, Kapil. We have another question. What is the significance or differential of thickened diaphragm? How can that help you? Thanks. So why does it even matter? Why are we looking for a diaphragm that's thickening?
Diaphragmatic excursion or thickening? Thickening, I think it is more related to spontaneous breathing trials, that if it is not thick enough or if it doesn't thicken enough, then it will not be very easy to wean off a patient. What I feel is, in our ICU training during our residency days, we were taught that if your diaphragmatic movement is not good, it's also based on some kind of nutrition. So if the nutrition or proteins are not adequate, it will affect the diaphragmatic contraction as well. So maybe that might be the reason. I'm not sure exactly the theory of what and why this thickness would be significant, but that's what most of the studies have validated, that the thickening fraction correlates very well with the spontaneous breathing trials. I think so, that maybe the diaphragmatic muscle contraction, whether it's good or bad, it should correlate. What do you think, Shara?
Yeah, that's hi, Mohammed. Yeah, thanks, no problem. Yeah, that's exactly what they've shown, is that patients who don't have adequate diaphragmatic thickening have a higher failure rate with extubation. So, this may be one of those things where you have a patient who's really weak or has been critically ill for a while, and you're wondering if you can get the breathing tube out, and maybe they've passed their spontaneous breathing trial, or they're kind of on the border with a spontaneous breathing trial, and then you do the diaphragmatic thickening assessments the thickening fraction and they're impaired, they're not adequate, and those patients tend to fail more than the others. So that's kind of the clinical significance of it. And I know too, in the world of anesthesia, one of the things that in looking at excursion, that people are really interested in is for blocks. Like if you put in a block and you bag the phrenic nerve or something, then how is the thickening getting affected, and are the patients, are you at risk basically for the patient to be in respiratory distress, or do you need to support them more? And Dr. Morris just said, I use it in pulmonary consult service a lot to evaluate dyspnea. And I don't know, Amy, I know you're out and about, but I don't know if you could elaborate on that a little bit more, like how it changes your management when you see that the diaphragmatic thickening or the thickening fraction is reduced in
Can
your...
you hear me? Sorry.
Yes.
Okay,
yeah.
Sorry, I'm in a quieter place now. Yeah, so I find this is really an underutilized tool, both inpatient and outpatient in the pulmonary world, and it helps me differentiate sometimes when I'm presented with the patient with shortness of breath in the acute setting, particularly post-operatively, like you guys see. You might see a unilateral diaphragmatic paralysis, or if it's more chronic, a unilateral diaphragm that it's been denervated long enough that it's thinned and it does not thicken any longer. But the combination of less excursion, less thickening suggests a weak and potentially a chronic process, particularly if it's bilateral. So trying to differentiate somebody who's got an acute reason for dyspnea in the hospital versus somebody who's just chronically weak can sometimes be helpful. Evaluating patients both in the clinic and in the hospital, but the lack of thickening and excursion, the combination of the two, I find particularly useful, and whether it's unilateral or bilateral, it just helps me in my differential as I'm evaluating why this person might be short of breath.
Thank you so much. That's super helpful. Yeah, and you could see that too, like I think from our standpoint, if you were doing a regional technique and you had all of a sudden some dyspnea or something was going on, oftentimes we're doing multiple things. Maybe we're putting in a central line and we've done a block or whatever the case. And then, you go and you do an evaluation and you see that on the side of your block, the diaphragm is thickening and, moving the way that it should, but on the other side, it's okay. That may be really helpful to help you understand how to support the patient and what the next steps might be. So I know that clinically, these are the ways that we've been using it. Samuel, thank you for a beautiful talk. My question is, how much B lines are we expected to see on a single view? Samuel, I'm assuming do you mean in a normal patient or in a patient with pathology? Or maybe we can talk to both of that, Kapil. So how many B lines would you expect to see in a patient who had pathology? And do you see any B lines even in normal patients? Like, could I have some B lines, for example?
Yeah, so basically we see more than B lines are significant. Anything more than B, right? Is it right?
Anything 3 or more.
Yeah.
Within a field between 2 rib spaces.
Yeah. In one field, yeah. What do you think? What do you think, Samuel?
Samuel, were you gonna, I'm sorry, I think you may have unmuted yourself. Was that the question that you were hoping to ask?
Yeah, my question is, thank you for this talk. I wanted to know how many B lines can we see on a single film, or a single view for a normal lung, and then how many of them do we say this one is
normal
considered
lung any B lines? Normal lung would not have B lines. They would have Z lines, Z lines.
Z lines.
I showed was different from the B lines. Only in pathology, you will have B lines. So either it is consolidation, but if it's only restricted to one portion of lung, but if it is generalized all over in both the lungs and also in all portions, then it is pulmonary edema. And anything more than 3 lines is significant.
And I would just say that, like, it is normal to have sometimes a little bit of air and water. So you may see 1 or 2 B lines in a normal patient, maybe. But like Kapil said, if you see any more than 3 or more, then that's abnormal within a field. And a field is described as between 2 rib spaces. And how many could you see? You could see a ton. Sometimes you could see so many that it like basically looks like a bright whiteout, like just like a big flashlight of light.
Basically, it
without
quantifies. So the more B lines you have, that means the bigger problem is there. That means it's a bigger edema, like more volume of fluid is there in the lungs. So it quantifies. As the patient gets better, the B lines number will also decrease. And Sarah, is it okay if I leave because I have to start a case soon and it's a vascular?
Yes, I have to actually go too because I have an aortic valve replacement case to start. So we're both in the operating room today. But we just wanted to say thank you so much, Kapil. Thank you so much. This was an amazing talk. I want to thank you all for joining and for all of your insightful comments and questions. We really appreciate it and hope you have a wonderful day. See you next month. Next month, you guys have to come because we are going to have a national leader in cardiac ultrasound coming to talk to us about point of care cardiac ultrasound in patients with cardiac arrest. So please spread the word. We'll send out a reminder email and we look forward to seeing you then.
All right. Thank you. Thanks everyone.
Bye. Thanks, Kapil.
Yeah.
Thank you very
Bye.
much.
Bye.
Bye.